Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for March 19th, 2025. Thank you for joining us today, and thank you to the current OA Action Alliance sponsors that are shown here. We are grateful for their help and support of our work, which includes the monthly Lunch and Learn series. I'm pleased to introduce our speaker. Chris Kuenze is an associate professor in the Department of Kinesiology and the co-director of the Exercise and Sport Injury Lab at the University of Virginia. His research interest includes the impact of anterior cruciate ligament, or ACL injury, and surgical reconstruction, or ACLR, on physical activity participation, and how changes in physical activity influence knee joint health. The goals of his research are to facilitate a safe and timely return to healthy levels of physical activity following ACLR to promote positive long-term joint health and well-being. Chris is also the director of the ACL Reconstruction Rehabilitation Outcomes Workgroup, a 13-site clinical research collaborative focused on characterizing rehabilitative characteristics and enhancing rehabilitative outcomes following ACLR. Chris has authored or co-authored more than 100 peer-reviewed journal articles, presented at a variety of national and international meetings, and has obtained funding to support his work from numerous public and private sources. The title of today's presentation is Beyond the Field, Living with Chronic Burden After an ACL Injury. Welcome, Chris.
Thanks for having me. I'm really excited about today's talk, and thanks for everybody who joined us this afternoon. So yeah, my goal today is to talk through some of the research we've been doing over the last maybe 5 to 7 years, looking at the period of time between structured rehabilitation and some of the long-term maybe negative outcomes that we've associated with patients who have had ACL injuries or ACL reconstruction. Before we get started, I do just want to disclose that I'm a paid consultant for Inova Health in the Fairfax area as a data analyst. And here's a summary of my current roles, which were already well described. So the important thing for me is to think a little bit about the motivation behind my work. I have had numerous knee surgeries that have gotten increasingly serious over the last 5 to 7 years. So I've lived the experience that many of my patients or that your patients go through as time goes on. And so as my career's progressed, my interests have also changed quite a bit from things like in-lab biomechanics and other more basic or translational measures to really giving some consideration to the patient experience throughout rehabilitation and beyond. And the second thing is that as a lab director over the last 10 years, I've probably had somewhere between 1,000 and 1,200 patients with ACL reconstruction through the lab. And you start to see families like the one on the right side here. This is the Brogan family from Lansing, Michigan. They gave me permission to share this photo. This family has been absolutely decimated by ACL injuries over the course of the last 15 years. Just in the photo alone, there's nearly 10. And within their broader family, there's something like 21 total ACL tears that have gone on. I'm sure there's a genetic component. But when you interact with these folks, it's sort of a resignation to the fact that they're going to have an injury and it's going to negatively impact them moving forward. And so trying to develop a line of research that enables us to actually help folks kind of bridge the gap from their rehabilitative experiences to long-term healthy behaviors has kind of been a passion project for me over time. Unfortunately, we've got kind of two realities. We've got the reality that we talk about as researchers and clinicians. That's what's on the top of the figure here. The goal is to have clinical care that progresses through rehab. We then have this idea of return to sport and continued biologic healing that's followed up by a healthy level of lifelong physical activity. And the whole idea here is that we're going to reestablish cardiovascular fitness and musculoskeletal readiness, and then move towards a maintenance of cardiometabolic and joint health over the long term. The issue we run into is that our goals are not reflected in what's actually happening for the majority of our patients that are progressing back toward return to sport or other forms of physical activity, or in some cases, no activity at all. When looking at the literature about the reality of the patient experience beyond a year after ACL reconstruction, we see that there are both differences that are deleterious as compared to healthy controls in areas like symptoms, moderate to vigorous physical activity and changes in body composition. But we also see that there are elevated risks of long-term morbidities. And so things like the risk of myocardial infarction is higher. Those studies are in ex-NFL athletes, so it is important to qualify that, but there does seem to be some linkage there. Higher prevalence of cardiovascular risk factors later in life. That's a paper we published a few years ago. And then also things like persistent knee symptoms and the incidence of knee OA. And so there's some disconnect here that I'm sure at some point has to do with the quality of surgery and the content of rehab, but it also means that there's a continued process that's occurring between the time that patients disengage from the healthcare system and as these kind of negative outcomes or negative risk factors develop over time. And that's really where I've started to spend a lot of my time is what is the pathway for patients after they've been released for care, and how can we set them on a path that sets them up for hopefully what's on top of the figure instead of what's actually occurring, which is represented on the bottom. And so when we look at this, we kind of can simplify it down. This is overly simplistic, but we know that at 1 year, there are some negative outcomes that might be indicative of longer term disease processes or negative outcomes. And we know that in the lifelong reality, there are some things that have been measured among patients who have had ACL injury and ACL reconstruction. And I just keep coming back to this family of people who have had this injury over and over and over again. And we've done a really good job at thinking about the front end. How do we optimize surgery, and maybe what are some rehabilitative characteristics or the duration of rehab that might help patients? And then we've done a really good job at characterizing what happens in the long term. How many people get radiographic osteoarthritis? How many people have unacceptable symptoms? How many people are active later in life? But the middle, this kind of area where life actually happens, where this wedding happened and where other things in the Brogan's family have been going on, is sort of this area that we don't really give as much thought. We've done some cross-sectional work, but we don't think about what an intervention for someone like this would be to help promote long-term well-being and quality of life. And so I always like to start by thinking about what is the patient expecting from the procedure after their injury. And so most patients that I've seen come through my lab and through the clinics in the institutions I've worked at, they have this kind of top pathway. They think they're going to be injured. They probably were injured playing sports. They're going to go through treatment, which includes surgery and rehabilitation, and then they're going to progress back to the sport that they're interested in participating in. And because of that, they're going to be active and healthy in the long term. Now, I guess this would be a really informed patient. I'm not sure that many 13-year-olds are thinking about like long-term activity and long-term joint health. But in general, they kind of purport to this idea that returning to sport is going to be good for them in the long term. What we see is that there's a fair number of patients. Our 1-year reality is that there's a good number of patients here that have entirely given up sport, and there's a fair number, like almost 75% according to Webster et al. I think there's been some papers since that have said this is probably closer to 40 or 50% of patients who haven't returned to their full pre-injury sport status by 1 year after surgery. And so those patients need an alternative pathway, right? They're not successful in returning to sport in a timely manner or potentially at all. And a lot of these folks are young. They're in high school. They don't really have access to other opportunities for physical activity. And so we need to think about what would a strategy look like for them in order to achieve this active and healthy lifestyle in the long term. At 2 years, things do look a little better. We've got 82% of patients self-report that they've returned to some level of physical activity. So that's good. And I guess that would be considered better than what surveys of like the American populace would be if we just asked everybody. But only 63%, in this study, and there's been some others that kind of back this number up, return to their pre-injury sport status at 2 years. And so these are definitely people that have taken an off-ramp at some point during their rehabilitation. And there's nothing really waiting for them at the end of that off-ramp. They just sort of are out there in the world trying to figure out how they're going to re-engage in some level of activity that's going to keep them healthy, or maybe no activity at all, and they've decided for a shift in lifestyle. And that's sort of a challenge for us because we assume that everyone's kind of doing well, the top of that earlier figure, and we're still seeing the negative outcomes related to activity and long-term morbidity. And so I started investigating this problem by looking at kind of device measured approaches to physical activity. And in our early studies, in collaboration with Dave Bell's group at the University of Wisconsin, we started very simplistically and looking at some cross-sectional work, just comparing age, sex, and activity level, or pre-injury activity level matched patients with ACL reconstruction and healthy controls. And we found that ACL reconstructed individuals participated in significantly less physical activity per week. And as you can see on the right side, there's a recent meta-analysis that was released that summarized kind of all the studies to date that have used device-based measures of physical activity in patients with ACL reconstruction. And we can see that there are some meaningful kind of moderate to large effects for ACL reconstruction status when we're looking at MVA per week or per day, meaning that these patients, in the majority of these studies, were sort of somewhere between 9 and 60 months after ACL reconstruction. These folks have persistent reductions in physical activity as compared to other healthy individuals who have not had surgery. We've also seen, as our work has grown over time, we've started to measure patients later out after surgery, even as far as 2 years after surgery, to see what their physical activity profiles look like. And we see a remarkably similar graph. I mean, we see that patients that are 2 years out still experience reduced physical activity after ACL reconstruction as compared to healthy controls. And when we look at the odds of them achieving what we would consider physical activity guidelines for cardiovascular exercise, this does not include the strengthening guidelines, we see that patients have about 2.5 times lower odds of being physically active. And so these are folks who some returned to sport and others didn't. There's pretty homogeneous activity profiles within both groups. And we see that regardless of return to sport or not return to sport at 2 years, we're still observing reductions in their physical activity engagement. What's the cost to the patient? Well, when we look at things like body fat percentage, when we look at VO2 peak, and when we look at pulse wave velocity, which is kind of a leading indicator of the development of cardiovascular risk factors and cardiovascular disease, we see that patients with ACL reconstruction have poorer adaptations to their injury than a healthy matched control would have at a same age and same sex and same self-reported activity level. Patients with ACL reconstruction tend to have higher body fat. They have lower VO2 peak. This was a bike test, but we've replicated this in a treadmill test. And they also tend to have higher pulse wave velocity, which is a poorer outcome in this patient population. And so why is this shift occurring as patients report that they should be returning to sport? They expect to return to sport, or at least expect to return to some level of physical activity or other healthy behaviors. And so we've talked to a lot of patients. Our research has, if you talk to my doctoral advisor, he'd probably chuckle, because as a doctoral student, if you had asked me if I'd ever do a qualitative study, I probably would have walked in the other direction. But over the years, my agenda has changed quite a bit, and we've done a series now of qualitative studies to better understand why this is happening, not just what is happening. And so we started with this paper that was published in 2018 in JOSPT. And there we just talked to 10 adolescent patients who had not yet been cleared for activity, but were very close. And we wanted to understand better what their perceived barriers to rehabilitation or to return to physical activity would be. And then we also looked to better quantify or qualify what positive and negative rehabilitative factors might be in helping to promote their successful return to physical activity. And when we did that, of course, things broke down really nicely into this kind of biopsychosocial, kind of breakdown. But we saw that things like pain and discomfort were limiting their ability to engage in activity. We also saw that they were uncertain about their progress, kind of where they were in their rehabilitative timeline. And that uncertainty was feeding a sense of fear of re-injury or fear of reintegration into the activities they were participating in prior to their injury. And they were also adjusting to some social changes. So young people are normally part of a sports team when they get injured. In a lot of cases, this is a really elite or sort of committed sports team. And they were trying to get used to this idea that their role on the team may not be ready for them when they get back. And what would that mean for them? Would they not be able to play on the team any longer? Would they have to only play in sparing moments and then have to train separately? And we're not the only people that have found similar things to this. Julie Berland has reported similar kind of physical or biological, psychological and social adaptations to injury in patients who are further out from injury and who are a bit older. And Mark Paterno also found the same thing in a different kind of study design here. They were looking at some key drivers to rehabilitative outcomes, and we could map that onto the same type of structure. So patients here are not reporting anything that's exotic, but it's interesting that across studies, across populations, and across timelines, patients are reporting kind of similar things: social support or social role, fear, uncertainty, all of these things that are potentially manageable or intervenable. But at this point, we haven't necessarily developed things that would enable us to be effective in doing so. We've tried to develop a new survey to get at this question a little earlier and a little bit more directly. And so you can scan the QR code. It'll take you to a repository for kind of open science where we host our survey currently. You can download it in multiple versions. But I was really interested in asking patients a little more directly, what is your physical activity level? And we tried to incorporate 3 levels here based on the qualitative work we've done previously. We've asked people, do they perceive that they're as physically active? Do they perceive that they're as physically active, but it's a lot harder, either physically or mentally, or that they're less active? And patients who report that they're as active, but it's more challenging, or that they're less active, then can select reasons for why they report that change. And so we did an exhaustive literature search of qualitative and quantitative studies to try to figure out what the 14 kind of most commonly reported reasons for decreased activity or decreased participation in sport were after ACL reconstruction. And so we settled on the list on the left. And what we observed is that about 40% of patients at about 9 months after surgery reported that they were as active as they were prior to surgery. So this is patients who are cleared for full return to activity and are out in the world engaging in that activity. But we also saw that 29% reported being less active, and about 30% indicated that they were as active, but it was more mentally or physically challenging. And when we actually looked at what the reasons were, what we can see is that in orange, we've got they're as active, but it's more challenging. And in blue, we've got the patients who reported being less active. We saw some predictable things, I think, that we expected, like knee symptoms. If they're having symptoms when they engage in activity, it makes them less likely to want to do that. Fear of knee symptoms or fear of movement. So just the idea that they might have symptoms or that movement might be painful limited their ability to engage. And we also saw that fear of injury was a kind of commonly reported for both groups. I do want to draw your attention all the way out to the right side. We also asked about concern that activity will worsen their knee health, and this will come back up later when we talk about patient education. But we definitely saw that patients were concerned that if they did too much activity or the wrong kinds of activity, it might also reduce their knee health. And so as we've kind of looked at these things, we've tried to map them onto a model. I work closely with Shelby Baez on a lot of this work. She's at the University of North Carolina, and she adapted the kind of fear avoidance model a few years ago to be a little bit more specific to activity engagement in patients with ACL injury and reconstruction. And we've done a series of papers that I didn't have time to present today, kind of looking at avoidance behaviors and injury-related fear and how that maps onto physical activity. And we're pretty confident that there's a relationship here between reduced activity and engagement and increased avoidance behaviors or increased injury-related fear. But we were unsure of how knee symptoms kind of played into here because it was such a commonly reported concern by patients who had reduced their activity level or had more challenges. We wanted to investigate that. And so along with Shelby and Matt Harkey, who's at Michigan State University, we've done 2 kind of big studies. We've got a few others that have been published recently that tried to apply criteria. I think we've kind of changed terminology in this area quite a bit from OA illness to early OA. I tend to think of this really just as unacceptable symptoms. So these are high levels of symptoms that patients are experiencing that really we would hope they should not be by the time that we've evaluated them. And we started with a cohort of 300 patients who are kind of in early adulthood, about 6 months after surgery, just trying to get a better understanding of what their symptom level looked like. We applied the Luton criteria, just the symptoms part, not the imaging part. And we found that at about 12 months, we had roughly 31% of patients were still reporting what we would consider to be unacceptable symptoms using the original Luton criteria. Matt Harkey's also proposed using kind of PASS scores instead of the original kind of guidelines that have been used for the Luton criteria. If we even did that, which is a much more conservative measure, we still saw that 26% of patients at 12 months were still experiencing unacceptable symptoms. In a later study that we were lucky enough to gain access to data from New Zealand in their ACL registry, you can see in this study that we had over 3,000 patients who had data at multiple time points and 10,000 patients that had data at least one time point. And in this case, we saw that if we're looking out from 6 months all the way out to 24 months, obviously kind of earlier on, we would expect more patients to have symptoms. In this case, like 68% did. But even out at 24 months, there's still 46% of patients that are reporting symptoms that would be characterized as unacceptable and potentially limiting their physical activity. As we saw earlier, patients who have limited activity report that symptoms are a primary driver of that problem. And so we've kind of started to map out this kind of model to try to understand what it is we can do to try to alleviate some of these barriers and increase activity engagement to make positive changes in long-term health. And so 2 areas that we thought about are injury-related fear and also trying to improve kind of this idea about information about the illness or injury in order to improve response. And so we saw here that concern that activity will worsen your knee health was a kind of a highly loaded question here. I think there's been enough work that shows that engagement in activity is probably good for health and joint health if it's done in a responsible way. And so we think of this as maybe an indicator of some incorrect information or poor quality information that's being passed on to patients. We've looked at what would help patients and what would not help patients, and patients themselves report that higher quality, clearer, and more consistent information about their recovery and about the long-term consequences of their injury would be very helpful, and that generalized approaches to treatments or guidelines are not very helpful. We've also asked, like, do parents and physical therapists of young patients get the same message? Do they feel the same way? And so we interviewed adolescent patients, parents of those patients, and their physical therapists a few years ago to better understand kind of whether there was consistency or lack of consistency between stakeholders. And we were able to develop a single thematic structure because there was such tight overlap between messages from stakeholders. And almost the entirety of the feedback from all 3 stakeholder groups was that things like consistency of knowledge, communication, and quality of information provided to patients was severely hindering their ability to make a timely recovery and also know what was and what was not safe for them to re-engage in after their surgery. And so what are we doing to help, right? I am coming to the end of my time here. I want to make sure that we're able to get back from lunch, but the goal here is that we're trying to plug in some interventions on the bottom side of our figure to help alleviate some of the development and long-term concerns that patients are currently dealing with. And so in the patient education side of things, through the ARROW work group or the ACL Reconstruction Rehabilitation Outcomes work group, we've got a repository now of almost 5,000 patients worth of data, most of which have multiple time points. We've got long-term re-injury data and return to sport data on more than 1,000, return to sport data on more than 1,000 and re-injury data on more than 2,000 of those patients. And we've been able to start developing with the School of Data Science here at UVA clinician and patient-friendly tools for them to be able to better understand the trajectory of their recovery and also to be able to have more informed conversations with their clinicians, especially during the period of time when they're transitioning from formalized care out into the real world. It's kind of a report card setup. This is the mobile app that we've kind of put together through Power BI, but there's also a desktop version. And so we're trying now to understand how patients interact with that tool and whether or not the current design is helpful. So that work is currently ongoing. And then our other area of focus is, can we start to pair some interventions that alleviate injury-related fear and develop some educational interventions that patients can engage with, while also giving them physical activity promotion intervention through wearable technology. So is there a way for us to help alleviate some of the long-term concerns or persistent concerns that patients are experiencing, while also kind of trying to facilitate their engagement in activity? And so our hope is that by doing that, we can also have a positive influence on those persistent symptoms that are so common, because as we increase activity, we hope that will reduce potentially body weight and improve body composition, which both should have a positive impact on knee-related symptoms if they're maintained over a period of time. And so with that, I'll say thank you. I think I'm right on time, and I'm happy to take any questions that the group may have.
Thank you so much, Chris. That was extremely interesting. And yes, you are right on time. We are going to open it up for Q&A for anyone who wants to type a question into the chat. While we are waiting for people to percolate on their thoughts, I do have a question for you. Given that there are sex differences in primary injury risk and some early rehabilitative outcomes following ACL injury, does patient sex or any other demographic factors have an impact on burden caused by ACL injury later in recovery?
Yeah, it's a great question. I think there's been a recent meta-analysis that looked at some patient-reported outcomes that indicated that maybe there weren't large differences between sexes during recovery. I think our work has shown something quite differently. In general, we've seen that women are at greater odds of reporting unacceptable symptoms both early and late after ACL reconstruction. I think that data goes all the way out to maybe 3 years after surgery. We've also seen that in qualitative work, I think I may even have the figure. I might have put it behind. Yeah, so in qualitative work where we interviewed adolescent male and female patients, we found that there was some overlap in areas of concern around return to activity and about their injury, but their processing of the information and the types of information they were interested in obtaining were really different. And we've mapped this onto some psychological outcomes that Shelby Bias is very interested in, like fear of re-injury and fear avoidance. And then, of course, we've seen some differences in things like biomechanics and gait mechanics and things like that. But yeah, I do think that there's some meaningful differences here. I'm not sure that we have a great idea of how they map onto the actual long-term outcome, though. And so I think that's work that's ongoing, and we're hoping to have a better idea of that soon.
Thank you for that. I do have another question. Are patients, especially young patients, aware of the chronic challenges that they may face over the mid to long term? And if so, how do they respond to this new reality?
Yeah, I don't think so. At least not in the way that we might consider it. So I think a lot, not I think, in our interview studies, I've been the primary interviewer for the majority of these studies. So I've spent quite a lot of time with adolescents and their parents. Um, and I think the thing that we've noticed is that the patients definitely are aware that this is a life-changing event, and that life around activity is much more challenging than it was before they had their injury and surgery. I'm not sure that patients are really aware, especially on the younger end of the spectrum, about things like risk of development of arthritis or other kind of more chronic conditions that might develop as a result of having had their surgery or their injury. I'm also not sure that that's something that we totally want to give them. I'm not sure that we want to spend a lot of time trying to make them upset or nervous about that. I mean, it's nice for them to have the information, but I also get nervous about it hindering their ability to, be confident and healthy and happy in their return to sport. So there's some balance in there. I think clinicians have tried to strike that balance to the best of their ability, but I'm not sure that especially younger patients have a very good kind of view of the whole field as they're trying to figure this kind of pathway out for themselves.
Yeah, that actually tracks really well with, I think you're familiar with the OA Action Alliance's Remain in the Game toolkit and app where we're trying to help young athletes to take on neuromuscular training for during their warm up to prevent injury. And when you go through that, you'll notice there's really very seldom, if any,
Mhm.
mention of arthritis. We know that that's what the purpose is, but
Right.
yeah, we want them to be thinking, and we also are aware that they're not really thinking about their 40-year-old self. So,
Yeah. Oh,
want
absolutely. Yeah.
yep, very good. All right. So I don't see any questions in the chat. Given that we're at 12:30, let me just queue up our April 16th webinar for people that are on before you hop off, just to make you aware. that we hope you'll join us on April 16th for the Lunch and Learn titled Community Partnerships to Enhance the Reach and Effectiveness of Walk with Ease Programming, featuring Dr. Greg Welk. So we hope you'll join us. But for now, thank you again, Chris. Really interesting presentation. And thanks to all of our attendees for taking 30 minutes to eat their lunch with us today.
Thanks for having me.
Thanks, everyone.